All right, it is 6:45. Welcome everybody to our February 22nd Grand Rounds. Today, we are honored to have Dr. Troy Woodard. He's a full professor of otolaryngology, head and neck surgery, and a fellowship-trained rhinology and skull-based surgeon at the Cleveland Clinic. He's had, despite his youthful looks, over 2 decades and plenty of time to develop both the national and international reputation in all breadths of rhinology and skull-based surgery. He has published numerous peer-reviewed books, chapters, and given lectures around the world. He has recently completed a turn as the chair of the Board of Governors for the AAO in 2022, and uniquely enough, he is the first African-American to hold this position. He's been recognized with numerous awards and honors for his achievements. In addition to his academic efforts and endeavors, he has developed a reputation for his community engagement and his mentorship. He has been passionate about all efforts of increasing diversity at the Cleveland Clinic and nationwide. He has developed a national medical speed networking initiative that helps to teach and inform students about otolaryngology and to meet a diverse group of otolaryngologists. He's been tireless in advancing the efforts of all that he is passionate about, and we are honored to have him here today. Dr. Woodard, please take over.
All right. Thank you. Really appreciate that. It's an honor to be able to present this morning. And, you know, I know some of you are probably thinking, oh, God, HHT, right? And it's kind of, I remember as a resident and even as an early attending thinking, oh, this is a horrible disease. You know, it slows my patients or the flow through my clinic because the patients are bleeding everywhere. And then when you think on the patient side, they're pretty miserable, right? They have a low quality of life. And over the years, I have started to use a newer technique to treat these patients. And I can say it has changed not only the patients' lives, but my experience with these patients in the clinic. I'm so really ecstatic about this. I wrote my trialogic thesis on this. And hopefully by the end of this talk today, it will have you thinking about when you see your next HHT patient that you may want to try some of these novel therapies. Okay, so I have no relevant disclosures to this presentation. During today's discussion, we're going to briefly discuss the pathophysiology of HHT, then talk about how you diagnose it in patients. We'll then focus on the clinical manifestations and ways to detect the different telangiectasias and AVMs. However, we're going to focus mostly on the nasal manifestations. Lastly, we'll discuss novel treatment strategies, both medical and surgical. So this number has grown actually significantly over the past few years. There are approximately 31 centers of excellence in North America. Now, what defines a center of excellence? Well, really, it means an institution is able to provide a multidisciplinary approach or comprehensive care of these patients. So, for example, UCSF, your center of excellence. Why? Well, you have different specialists able to treat the different organs that are affected by this disease, thus providing comprehensive care to the patients. So let's begin just by briefly describing HHT. It's a multi-system disease affecting the connective tissues and elastic fibers of the vascular throughout your whole body. So these patients generally have vascular dysplasia, and they lack or have inadequate elastin and smooth muscle fibers. This makes the vessels really thin-walled, and they're friable. They can easily burst and rupture. Usually you will see these lesions on the skin, the mucosa, and the mouth, etc. It affects approximately 1 in 5,000 people, present in all racial and ethnic groups, and it's located over a wide geographical areas. It's an autosomal dominant disease. 90% though of the mutations are in the TGF-beta angiogenic cascade. There are several forms of HHT. The 3 primary forms though have mutations in the genes ENG, ACVRL1, and SMAD4. SMAD4 is associated with juvenile polyposis syndrome. So when we take a deeper look, what actually happens at the level of the blood vessels in a patient with HHT? Well, if you look on the left, you'll see a diagram showing the normal capillary bed. You have your arteries that break down into smaller arterioles, then to capillaries, and then they go back through work their way through the small veins or venules back up to the larger veins. However, if you contrast that with a patient with HHT, you have loss of the capillary bed. In addition, many times the arteries directly connect to the veins. So the large arteries connect to the larger veins, and oftentimes that leads to shunting of blood. Remember though, these vessels are very thin walled and can easily rupture. So PARC, well, first let me just say, during wound healing, there's an upregulation of the genes that promote angiogenesis. And PARC actually wanted to take a look and see what happened in the vascular level. So he compared normal mice to mutant mice that had a mutation in the ALK1, which is associated with HHT. He injected all the mice with blue dye. Well, if you look at the pictures to the left, you can see the blue dye in the normal mouse proceeded through the normal arteries down to the capillary level. Pretty much normal vascular structure. If you compare that to the mutant mouse, you can see there is really an aberrant vascular structure. You have, instead of the single artery displayed, you can see kind of double looping. It looks like two large loops. One is the artery, the other is the direct shunting into the veins, causing dilation of those veins. If you go further along the process, you'll see that the capillary beds are really disorganized compared to the normal mouse. However, I want you to note though, as you move away from that injury, farther away from the injury in the mouse ear, you can see that the aberrant blood vessels begin to fade away and go back to the normal structure. So this sort of suggested that this phenomenon occurs at the local level during wound healing. So you see a patient in your office, you kind of think they may have HHT. And so I'm going to just sort of explain how we define or diagnose a patient with HHT. It's a clinical diagnosis for the most part. Generally, patients will present either with epistaxis, it's spontaneous and it's recurrent. They have telangiectasias at multiple levels, multiple regions on the lips, oral cavity, fingers, nose. They also may present with visceral lesions in the GI tract, cerebrospinal areas, pulmonary or hepatic, and they have a family history of HHT. So we consider someone to definitely have HHT if they have 3 or more criteria present, possibly have HHT if they have 2 of these 4 criteria, and it's unlikely that they have HHT if they have less than 2. In approximately 85% of these patients, the genetic mutation can be identified, and it's usually those top 3 that I mentioned earlier, the ENG, ACVRL1, and the SMAD4. So when would you send a patient, though, to get genetic testing? Well, if you're on the fence and can't really tell, so for example, of that 4 clinical criteria I just went over, if they have 2 of those, it's a possibility that they have HHT. And so genetic testing can be used to really give you a definite diagnosis. Also, if you see a younger patient, younger adults or children, they usually have delayed penetrance and you're trying to plan for the future, we recommend genetic testing. And also, if you see someone who has early GI bleeding, that should raise a suspicion for SMAD4 mutation and possible GI malignancy. So how do we screen for pulmonary AVMs? We recommend the helical contrast enhanced CT. It's really more sensitive than angiography. As you can see here, the CT shows a small or thrombose AVMs. And when you look on the right, the angiography actually misses these. Cerebral AVMs are detected by MRIs. And actually up to 25% of the patients with HHT actually have cerebral AVMs. Their annual rate of rupture is 2 to 4% a year. So it's very important to obtain these, especially in patients who are presenting to you that have not had a workup. And so how often should you do MRI? Well, we recommend in adults after the initial study is obtained. If it's negative, there's no further screening. However, in children, we recommend doing one at birth and then every 5 years until adulthood. GI telangiectasias are common in patients with HHT. Actually, approximately 80% of patients have gastric or small intestinal telangiectasias. But of the patients who have this, only 25 to 30% of the patients will develop symptomatic GI bleeding. So as a result, we only recommend doing endoscopy in the anemic or iron deficient patient, because that could be a cause of kind of a slow, gradual blood loss. Usually these patients will present with GI bleeding late in the 5th or 6th decades. Again, if you see someone who's young, under 40, presents with a GI bleed, think SMAD4 mutation. So now let's get to the good stuff, the nasal manifestations. Well, as we know, patients who present to us really have a poor quality of life, right? Many of them can't work appropriately. I see patients all the time who come and say, yeah, I was, and this is kind of bad, but they'll say, yeah, you know, I'm a cook or I'm a lawyer and the blood just gets all over my work, right? And so the average age of onset is at 12 years, but they may start as early as 1. By age 20, 50% of the patients have significant nosebleeds. By age 40, 95% of the patients have significant nosebleeds. Now, note there's no correlation between the severity of epistaxis and the parents compared to their children. So if we can see here, what does HHT look like in the nasal cavity? So these are just pictures of endoscopic exam, and you can see all these small red dots diffusely scattered throughout the patient. They look pretty harmless, but if you touch one, it's going to bleed like stink, and then you're going to regret that. So how do I evaluate the patients when they come to my office, right? I try not to disturb these lesions. And when it comes to numbing, I do not put any, lidocaine soaked pledgets in their nose. I kind of stand back far away from their nose. Well, not too far, but enough to where I can just aim in the hole and squirt. And that way I do not provide trauma. And then when I go in with my endoscope, I really just peek in at the anterior portion of the nose and look throughout. One thing that I use, actually the patients use to kind of keep track of their tests, the amount of bleeding, when they bleed, is an app that you can find on the Cure HHT website. And really, this is good so that patients, when they present to me, they can really give me an accurate history. And also, they can stay on top or abreast of any scheduled exams or tests that they need to get done. Additionally, I use the epistaxis severity score to really guide my management. So the severity score is a real short 6-question survey that asks the patients, are they bleeding? How long they're bleeding? Do they require any type of infusions? If they bleed, describe it. Are they gushing or they're just little drops? And you get a score between 0 and 10, 0 meaning no problem at all, and 10 meaning you have severe epistaxis related to HHT. So in patients with mild numbers or mild epistaxis severity score, we use typically just the normal medicines such as Afrin or oxymetazoline, humidification. Oftentimes, especially up here in Cleveland, in the winter, it gets really dry, right, and cold. This can predispose the patient to crusting and injury due to scab removal. So we have them rinse with saline and use Remupurus ointments. If that doesn't help, then we use our compounding pharmacy to make a vial of tranexamic nasal sprays. It's a 10% mixture in 30 mLs of saline. Usually, this helps patients during the time of acute bleeds. Now, tranexamic acid works by reducing the conversion of plasminogen to plasmin, and it prevents fibrin degradation. There was a randomized double-blind placebo control where they actually were able to detect a 50% decrease in nosebleeds. However, there was no significant improvement in the primary outcome. The hemoglobin pretty much stayed the same. All right. So if the tranexamic acid doesn't work, and then our patient has a moderate epistaxis severity score, we tend to move on with our medical regimen and start to prescribe non-selective beta blocker drops and sprays. Now, these beta blockers have anti-angiogenic properties. They cause apoptosis of the endothelial cells and reduction of VEGF expression. You may be familiar with, learning this if you're not a peds, Odo, but how propranolol is routinely used to treat hemangiomas in infants. And so it's kind of the same principle, except in the nose. We tend to use timolol. Again, oftentimes we'll get it from our compound pharmacy, or you can just prescribe timolol ophthalmic drops. It's commonly used, as you know, with glaucoma, but it can be used to treat superficial hemangiomas. There have been a few case reports demonstrating the effectiveness of timolol in controlling epistaxis. Additionally, there was a double-blind placebo-controlled trial in which patients were paired either to the timolol gel or the placebo arm. They received this twice daily for 8 weeks. The primary outcome now was the median change in epistaxis severity score and the percentage of participations reaching the minimal clinically important difference in their epistaxis severity score. Now, it was noted that the timolol group had a great improvement in epistaxis and quality of life compared to the placebo group. So we took a look at our patients, probably about 50 patients that had either severe or moderate epistaxis severity scores, and we placed them on topical timolol drops. And you can see from this bar graph that at 6 months, when we looked at our patients, a vast majority of the patients that started out with moderate scores on the epistaxis severity scale actually decreased to the mild score. Additionally, the patients who started out with severe epistaxis scores, about half of them were reduced to moderate or mild epistaxis severity scores. This actually persisted throughout 18 months. Now, please note though, there's still a good percentage of patients who had the severe epistaxis scores. They didn't really respond at all. And so what do you do with those, right? Well, we've tried Afrin humidification, myrpiricin, antifibrinolytics, timolol drops. So now we really start to bring out the big dogs. We start to use systemic medical therapy, angiogenesis inhibitors such as Votrient or Avastin. Now, what does Avastin do? Well, it can be given topical or systemic. It actually is a recombinant humanized monoclonal antibody. It binds to the VEGF receptors on the endothelial cells, and it really serves as a competitive antagonist. There have been several uncontrolled series reporting its efficacy and safety, especially in local administration. For instance, there was a double-blind placebo-controlled trial of 15 adult patients, and they were randomized either to intranasal submucosal injection of 100 milligrams of Avastin or placebo. And what they found was that the average daily post-treatment visual analog score decreased approximately 27% in the Avastin group compared to only 3% in the placebo group. Now, if we look at Votrient, It's typically given systemic. It can be IV or oral. It has been approved for really vascular tumors, renal cell carcinoma, soft tissue sarcomas, and it works actually at multiple levels, multi-targets. That generally it inhibits tyrosine kinase and blocks tumor growth and angiogenesis. So if we compare the two, you can see the Avastin or the bevacizumab is a competitive antagonist, and it's a monoclonal antibody that binds to the VEGF receptor, whereas Votrient works intracellularly to inhibit the tyrosine kinase cascade. So in our patients, we had a group of 6 patients that had very low hemoglobin scores. They were anemic. And initially, we started out by giving them systemic therapy of Avastin. Their hemoglobin actually responded very well, close to normal ranges. But after several months, you can see that the hemoglobin levels began to fall. Why is that? Well, you have to remember, Avastin is a competitive, antagonist. And so what the body does over time is compensates and develops more proteins to compete or outcompete the monoclonal antibody. So once that occurred, we gave all the patients Votrient, and you can see the hemoglobin levels actually increased to normal range, and they actually remained there even past 36 months. So oftentimes this is helpful in patients, but many times it is not. And so that's when you need to consider surgical therapy. All right. So there are different types of surgery that you could do to treat a patient with HHT. You can try electrical and chemical cautery. It really doesn't work very well. I'm sure you all can appreciate trying to use silver nitrate cautery on the patient with HHT in your clinic. Bad idea. It only takes one time doing that, and you realize you made a mistake. You can try arterial embolization. That works, however, it's very short-lived. And oftentimes, again, the patient will develop collaterals and compensate. You can do KTP laser, radiofrequency ablation with different devices, septodermoplasty, or even closure of the nasal cavity, a Young's procedure. Now, it's important to note with this Young's procedure, I'll sort of never forget this. I had a patient, it was when I first started treating HHT. He had the Young's procedure down in Georgia, and he came up, and I think he was probably about 1 week out, maybe 2, and he had massive bleeding. So you got to remember, this procedure doesn't work instantly. It's going to take a long time for it to become effective. And so he's bleeding down his throat, choking. It's horrible. And he's like, "Can you help me?" I was like, "Yes, but I have to reverse your Young's procedure." And he wouldn't let me. And so, we thank God he was able to stop on his own. But, that's something to really consider in the patient. If you're going to do the Young's procedure, you need to counsel them and let them know that this procedure is not instant. They still may have bleeds, and it may make it difficult if they do have a massive bleed to control it. And so what I started doing when I first got here, based on some of those papers that I talked about, was doing submucosal injections. And, I started out with Avastin, and it worked okay, but I still had many patients presenting to our emergency room with recalcitrant bleeding. And, I had to figure something else out. And I read about STS injections. And so I started doing those. And that's what I'm going to focus on now. So what made me sort of want to do the submucosal injections of Avastin was those studies that really demonstrated the 27% reduction on the VAS scale in patients. And what we did was look at our patients, and we kind of wanted to see the impact of cautery or laser with Avastin. And all patients really did well up until about the 6-month time frame. You can see that they had the pretty moderate to severe epistaxis scores, and it decreased dramatically down to the mild level at 6 months. However, after 6 months, you can see there is a dramatic increase in the epistaxis severity scores in our patients. And actually, only about 18 months, only about 56% of the patients remain at the mild severity range. And so I wasn't really happy with that and wanted to find something better. So I investigated sclerotherapy. So let me just tell you a little bit about its history. The concept of using foamy sclerotherapy was really described back in 1950. Orbach suggested by shaking the sodium tetradecyl sulfate, it would improve its thrombogenic effect. Other agents have been used, such as polydocanol, and actually it was used in epistaxis and first published in 2000. Now, how does sclerotherapy work? So the sclerosing agent induces irritation in the endothelial cells and subendothelial layers of the blood vessel wall. It causes irritation, it causes obliteration of the lumen of blood, and the lumen of the blood vessel, and it leads to fibrosis. It ultimately results in a collapse, thickened blood vessel, and it has very little blood flow. So in my opinion, it really just hardens it, also causes it to narrow internally, ultimately making it, I guess, a lot tougher for the patient to bleed at those sites. So how do I counsel my patients? Well, really, it's about being upfront and honest. I'm sure many of you have heard about this procedure and the possible risk and benefits. So basically, I sort of described the procedure. Now, I do it a little different than what some of the people who published on this method or procedure. They did it in the office. You know, it only takes 1 or 2 bad nosebleeds in the office for me to not want that to ever happen again. And so actually, I do sclerotherapy in the OR. And so I tell my patients, you're going to be asleep, but that allows me to really inject all the telangiectasias. I start posteriorly and work my way up anteriorly. This is in contrast to some other institutions that actually do this procedure in the office. Now, in the office, they're enabled to do all the procedure, inject all of the telangiectasias at once. And so usually the patient has to come back 2, 3, 4 times. I like doing it in the OR because it's a controlled setting. And it allows me to inject all telangiectasias bilaterally at one instance. Then I talk about the risk and benefits. Obviously, the benefits are to reduce the number of bleeds, the severity of bleeds, and then I talk about the risk. You probably all heard about that one case of unilateral blindness. I spoke to, and he won't mind me saying his name, but Picarillo. It was his patient. And it was very interesting because he utilizes the same technique that I do. However, in that instance, he switched it up a little bit. So let me just explain a little bit more. Usually we take the sclerotherapy or the sclerosing agent and we mix it with air. All right. We foam up the air and inject it into the telangiectasias. During that incident, he did not use air, he used saline. So he mixed the sclerosing agent with saline and then performed the injections. After talking to him, we sort of thought that by using the saline, it was able to produce more pressure. So when you're injecting, you want to have a low pressure lower than the arterial blood supply. And the thought is by mixing it with liquid, it resulted in higher pressures and then went retrograde into the orbit. And what was interesting, he said that during his experience, he was shocked. The patient was, blind. He stopped doing it for about 6 months. And so he called all his patients and was like, I'm not going to do this anymore. And he explained the case of blindness. And all of the patients were like, well, when you start doing it again, please give us a call. And so they were not phased. I think their quality of life was probably so bad that they still needed to be treated, and they were willing to undergo that risk. Again, since he started back with doing the procedure 6 months later, and he did it the original way with just air producing foam, and hasn't had any cases of blindness since. So let me just show you what we do. We foam the agent, and then we just you'll see some blanching of the tissues right there, and we inject every little telangiectasia. It's very hard to be precise. Oh, you may have some spillage of the solution. So let me explain something a little bit better. So I want to explain a little bit more on how you create this foam, all right? You get 2 syringes and a stopcock. One syringe is filled with 4 cc's of air. The other syringe is filled with 1 cc's of STS, so sodium tetradecyl sulfate. And you go back and forth, and it creates a foam, all right? We then use a 25 gauge needle to inject each lesion, and that's what you see in this video. Going back and forth, producing the foam, and then you go and inject the nasal cavities. All right, this is a picture of how it looks pre-injection on the left. You can see the large telangiectasia scattered throughout the nasal cavity. Post-injection, you can see that it's paler, and it looks like some of the telangiectasias have been completely removed. All right, so this is the picture to the right. It's approximately about 5-10 minutes post-injection. We then looked at the impact of sclerotherapy on our epistaxis severity scores over 18 months. And at 0.0, at 6 months after the sclerotherapy, 98% of our patients had their epistaxis severity score in the mild range. In contrast or comparison to the cautery or Avastin, at 18 months, 83% of our patients were still at that low mild epistaxis severity score. We then compared sclerotherapy to what could be called the standard cautery and coagulation. And if you look at the left, it's just as we wanted to prove that sclerotherapy is just as good as the standard cautery and laser. If you look from baseline out to 24 months, you can see that our patients did very well. And just like cautery and laser, the epistaxis severity score decreased to the mild levels. But I think the most important part that we should really take from this is the amount of procedures that each patient had to take or had to do over 24 months. And so you can see at 24 months, the patients who had the sclerotherapy agent really had a low amount of procedures. It ranged from 2 up to 4. And you compare that to the other group of patients who had cautery and laser, it was a significant difference. Those patients had anywhere from 2 to 8 procedures. So if we take a closer look, you can see that the majority of the patients in the sclerotherapy group really centered around 1 or 2 procedures over a 2-year time frame, where those in the cautery and laser group, the majority of the patients had 3 or 4 procedures done over 2 years. In my opinion, sclerotherapy is a total game changer. As you know, I sort of demonstrated, it's less number of required procedures. There is also significant decrease in postoperative pain, septal perforations. When I think about, I see a lot of HHT patients. I see about 2 patients every clinic. And so done hundreds of these sclerotherapy injections, and I've only had 1 perforation, which is pretty good. There's decreased crusting, and now I easily incorporate it into my clinical practice. What usually happens, I need to see the patient in person the first time. and get a good look of the intranasal cavity. We schedule them for surgery. After that, I'm familiar with their case, and so usually around 9 months or so, we'll do a virtual visit, and they may say, "Oh, I'm doing fine." And if not, they'll say, "Oh, well, I'm starting to bleed a little bit. I think it's time for another procedure." And then we'll get them on the schedule. The procedures in OR are very short, usually lasting less than an hour. I had one patient, actually, he's my first patient that I did sclerotherapy on. And he was a physician. He had to retire because he had massive nosebleeds. He would get blood transfusions literally every week to every 2 weeks. Very, very rough on this guy. And did the procedure. He's now, it's kind of interesting. He's become more adventurous. So he couldn't leave the house at first. Then he would go, once he did the procedure, he would go, just regular regional trips. And then, after the next time of doing the procedure, he calls me. He's like, "Yeah, doc, you think I'm gonna be okay? I'm gonna go up in the wilderness in Michigan and sort of camp for a week." And I'm like, "Well, I hope so." He did that, went fine. Then next thing I know, he's going on safaris in Africa. And the latest trip that he's gone on was a trip to Antarctica. And so he is so confident in this procedure and, the effectiveness of this procedure that really he's gone all around the world, to secluded areas. And so I think that sort of, to me, validates this procedure. I have not had any complications such as blindness, which is a good thing. I think this is a real game changer. So in conclusion, HHT is a multi-system vascular dysplasia. It has autosomal dominant inheritance. We know it results in a poor quality of life. Really, to get adequate treatment, you need to have a multidisciplinary approach and also consider the novel medical and surgical therapies that are out there. Thank you.
Thank you, Dr.
Any
Woodard.
questions?
We can entertain questions from the audience if anyone has any.
Can you discuss use of nasal splints?
I'm sorry, can you say that again?
I'm sorry. On one occasion, we used a thin silastic splint to prevent ulceration of the septum. It's kind of a barrier to dryness of the mucosa. Would you endorse that?
I've never done that. Describe it more. So is the goal to prevent like trauma from the air? Is that what you're?
I believe other staff have used this at UCSF. Being new here, I was recommended to use a thin splint. It's a very, I think, the thinnest silastic available, okay. And it's carefully trimmed to the dimensions of the septum, and then it's sewn transeptally so that the almost like a nasal splint after surgery, but
right, yeah.
And the patients noticed a significant reduction in bleeding. Certainly, I was very impressed with your talk. It's really outstanding. Opened up my understanding of HAT far beyond anything I understood before. So thank you so much.
No problem. As I think about what you described, it's probably similar to, I've noticed in my patients with significant septal deviations in HHT, the side that's deviated or closed off tends to be the better side. And so I'm wondering if you think about back to that slide where they had 2 mice and injury to the ear. I think, airflow hitting these exposed thin wall telangiectasias over time can cause trauma and lead to nosebleeds. And so by having either significant septal deviation, which allows less air, or putting these silastic stents in the nose to cover those lesions, preventing air to hit these thin wall telangiectasias, are what's providing benefit, if it explains my thought on what you said.
Excellent discussion. Just these patients you don't forget. I had taken care of a lady whose grandson suffered from a cerebral AVM, and it was such a huge impact on the family's life. So, your review is really outstanding. I really appreciate the outstanding
No
presentation.
problem. Thank you.
Dr. Pletcher, do you want to comment on the splint usage that we have here at UCSF?
Sure, I'll make a few comments, and happy for Dr. Loftus too. And Troy, thanks. Great talk.
Yeah, no problem.
Really appreciate having an expert in the field, and I particularly appreciate your comments on doing this in the operating room, because that was really the main thing that has kept me from really considering this seriously. Is that just the as you described, the situation you can find yourself in when you start manipulating the nose for these patients in the clinic is pretty challenging. And so I was having a hard time wrapping my head around how that would be effective. Yeah. What we do with the splints also is in the operating room. They're actually silicone, not stylastic. So they're flimsy and thin and less, more comfortable for patients. The typical versions come in 0.5 millimeter thick. There's a 1 millimeter thick, and then there's a 0.1 millimeter thick. And usually I use the 0.5 millimeter. So they're pretty thin. I'll put, usually 3 or 4 sutures in and just leave them in there. And it definitely decreases bleeding. The duration is a little bit variable depending on, kind of how patients respond with, some of the over time, the sutures can pull out or the splints can tear and things like that. But typically they're in there for years. And the biggest issue I would say is the patients do get them crusting. Oftentimes it's a little variable from patient to patient, a little bit of thick mucus. Some tolerate it great. Maybe I would say 5 to 10% I would take out in clinic because the crusting and debris and things is bothersome to them. So I find it's really helpful in the severe bleeding patient. And just as you described, it's really it's the airflow that causes these patients to bleed. And that's why the Young's procedure, once it kind of settles in, is effective because there's no more airflow. So this is just one more, kind of technique to try to achieve that.
Okay. Now, Steve, what I do perform in the office are injecting telangiectasias of like the lip or the tongue. That works very well in the office because usually it's just a few lesions. And I notice after injecting, it'll bleed probably for about a minute or two and it stops. So it's easily controllable there.
Yeah, great. And I find even for the challenging patients, manipulating them in the operating room, you can find yourself, with some difficulty controlling their bleeding there. What are your thoughts on that side?
So I love this because I rarely have to use any type of cautery or co-blader in the OR. What I do is they're put to sleep. To get rid of all the crusting, I form a mixture of half peroxide and half saline and squirt it in the nose, and it dissolves all the blood clots, all the crusting. Gently suction that out because if you go in and try to debride yourself, you're going to cause a lot of bleeding. And so I let the mixture do the debridement for me. And then I inject with just lidocaine with epi, 1%, with 1 to 100,000 lidocaine. And after that, I start posteriorly and inject each telangiectasia. If you looked at that picture that had the foam, it wasn't really bleeding much, right? And that's generally how it is. If there is some bleeding, once or twice, you may have a little bleeding. After you inject it, literally after about 3 to 5 minutes, it stops. And so it's amazing. And so I rarely ever have to use any type of heat when I take them to the OR.
Great.
Troy, there are 2 questions in the chat. One is how often do you recommend re-injections?
So generally what I've noticed, so remember like the way I put it in my clinic flow, we've averaged it out and it's usually around every 9 months or so, patients have to come back to get re-injected. If they're really, really bad, you may have to do the second injection, maybe around 3 or 4 months. But most patients can go about 9 to 12 months without an injection.
Related to that, you mentioned the one with the perforation.
Yeah.
Do you inject both sides at the same time or is it staged?
Yeah, so I inject both sides of the septum at the same time. You know, after speaking to Picarillo, this is interesting. He injected high on the septum, close to the anterior ethmoid artery location. I don't really, a lot of times, really high. I rarely see telangiectasias up there. So I inject the septum, but kind of from mid-level to low. And, you know, I think that's important to note too. But yes, I do inject both sides of the septum.
Next question was, are timolol or TXA prophylactic, or can they be used as abortive?
So timolol is prophylactic. It's going to take a while to shrink the hemangiomas. The tranexamic acid, it needs to be done with acute bleeds.
Gotcha. Dr. Loftus is our kind of spearheading the efforts of our HHT Center of Excellence here, Troy. So you will likely see and hear more from her as things go forward. Dr. Loftus, not to put you on the spot, any comments for this one?
Hey, Troy, good to see you. Great talk.
Thank you.
Yeah, I'm so interested because we are going to start offering sclero to our patients. We're really excited about it. And, you know, Jose and I went back and forth about the clinic versus OR, and we are planning to at least start it in the OR. But after hearing you, I think probably keep it that way.
Yeah, yeah.
But
because I find that, you know, patients get nervous, increases their blood pressure, they bleed, you know, and especially where I work, it's all about patients, see patients, more patients. And I'm sure that's expanding everywhere, you know, just because of the climate, you know, the financial downturn, and they want you to see more patients. And so to me, it just makes it a lot easier, a lot less stressful in the OR. And if you explain that to patients, they're fine with it. I mean, as long as you just give a good explanation, they don't mind. They just want to feel better.
Right. Well, I might be reaching out to you and once we get this started.
Oh yeah, no problem.
Okay.
Okay, we're at the bottom of the hour. Thank you, Dr. Woodard. Thank you, everyone, for joining. Have a wonderful week.
All right. Thank you.